I am going to describe an argument I have several times a month, usually with a pharmacist, occasionally with an insurer, and sometimes with a regulator. They look at one of my patients and they see 30-day quantities of a short-acting opioid, a lot of individual tablets, and they ask a reasonable sounding question. Why not consolidate this? One long-acting tablet twice a day, fewer units, cleaner, less to divert, better looking numbers. And I say no. Deliberately, in writing, and with reasons. First, let us be honest about where this pressure originates, because it is not primarily clinical. It is metric pressure. Enforcement actions and news coverage quote raw tablet numbers, because raw tablet numbers are vivid. Nobody writes a headline about morphine milligram equivalents, so a practice with high unit counts looks dangerous, even if its total exposure is low, and a practice that consolidates onto fewer, stronger, longer acting units looks responsible, even if its total exposure is higher. That is an optics problem being solved with pharmacology. And the pressure on pharmacies is real. I am not dismissing it. Major chains have faced substantial liability over opioid dispensing. Rite Aid entered Chapter 11 in October 2023, citing opioid litigation among its pressures, and settled federal allegations in 2024. Walgreens reached a federal settlement of at least $300 million over claims it filled invalid prescriptions. Pharmacists are operating under genuine corresponding responsibility exposure, and some of them are being squeezed by their own employers. So when a pharmacist pushes back on my prescription, I do not assume bad faith. I assume they are carrying risk they did not create. But I still have to answer for the pharmacology. Here is what we publish openly for dispensing partners to read. Pill count metrics, driven largely by enforcement headlines quoting raw tablet numbers, create pressure to consolidate a patient onto fewer, longer-acting units. That improves the optics of a prescribing ratio while, in our clinical view, worsening the pharmacology. We would rather defend a higher unit count at a low total MME than accept a lower unit count achieved through continuous receptor saturation. The mu-opioid receptor is built to be stimulated intermittently. Bind, signal, desensitize, recover, resensitize. Birdsong and colleagues showed in Molecular Pharmacology in 2015 how phosphorylation of the receptor's C-terminal tail drives beta-arrestin recruitment and desensitization. That is cellular work, and I always say so, but it describes a receptor with a duty cycle. A long-acting formulation is specifically engineered to eliminate the trough. That is its entire selling point. Smooth, continuous plasma levels, no peaks, no valleys, pharmacokinetically elegant. But the valley is not a defect. The valley is when the receptor recovers. Continuous occupancy means continuous desensitization pressure and no resensitization window. Over months, that is a recipe for tolerance and, in some patients, for hyperalgesia. The paradoxical amplification of pain I covered in the first video in this series. So my preference is the opposite of the intuitive one. More units, each smaller, with genuine intervals between them, at a low total daily dose. Now, mechanism is a hypothesis. If that were all I had, a pharmacist would be right to be unimpressed. So here is the outcome data, and it is the strongest part of my case. Ray and colleagues published in JAMA in 2016, Prescription of Long-Acting Opioids and Mortality in Patients with Chronic Non-Cancer Pain. Long-acting opioid prescriptions were associated with significantly increased total mortality compared with short-acting agents. And critically, the excess deaths were not only overdoses. There was excess cardiovascular and other non-overdose mortality, consistent with sustained systemic exposure rather than a single acute event. Miller and colleagues published in JAMA Internal Medicine in 2015. Prescription opioid duration of action and the risk of unintentional overdose among patients receiving opioid therapy. Long-acting agents were associated with higher unintentional overdose risk, with the risk especially elevated early in treatment. Two large studies in two major journals, both pointing the same direction. The formulation that produces the better-looking pill count is associated with worse hard outcomes. I have to add the honest caveat, and I add it in writing when I am asked formally. Both are observational. Patients put on long-acting opioids may be sicker or more severe to begin with. Confounding by indication is a real limitation, and neither study can fully exclude it. I am not claiming these prove causation. What I am claiming is this. When the mechanistic reasoning and the large-scale outcome data both point away from continuous receptor saturation, and the only argument for it is that the unit count looks tidier, the burden of proof is not on me. And I will name the counter evidence too because it exists. Chu and colleagues in the journal Pain in 2012 ran a randomized placebo-controlled trial of sustained-release morphine in chronic low back pain and found analgesic tolerance but no demonstrable hyperalgesia. That is a real result. It means my hyperalgesia argument is a clinical judgment, not a settled fact, which is exactly why I lean on the mortality and overdose data instead. Let me put real figures on this, because low total dose is meaningless without them. From our published protocol, our average patient is maintained at approximately 27 to 32.5 MME, and typical dosing is under 30 to 40 MME. We frequently inherit patients from primary care at 400 to 500 MME. Those patients are tapered deliberately, generally reaching a routine dose within 1 to 3 months. Fewer than 1% of our patients sit above 90 MME, and those are specific situations. Active cancer pain under co-management, or post-operative failed back surgery syndrome and arachnoiditis, where the elevated dose is a temporary measure during reduction, not a maintenance plan. Around 60 to 65% of our patients receive any opioid at all, and we wean most of them below 30 MME. Nearly all of them are receiving interventional treatment because we do not offer medication-only management. There is also a deliberate safety design in the dispensing pattern itself. We do not dispense more medication than a patient could foreseeably overdose on at one time, and patients on long-term controlled substances are seen in person every 2 weeks, with bottle checks at every visit. Smaller, more frequent, more supervised, that produces more tablets on paper and less risk in practice. Does lower dosing actually produce better outcomes? This is the right question, and the answer is encouraging. The SPACE randomized trial, Krebs and colleagues in JAMA in 2018, compared opioids against non-opioid medication for chronic back pain and hip or knee osteoarthritis pain. Opioids were not superior for pain-related function over 12 months, and the opioid group had more adverse events. High-dose opioid therapy is not buying the functional benefit that the escalation implies. The regulatory environment has caught up with this too. The CDC's 2022 Clinical Practice Guideline, Dowell and colleagues, deliberately removed the rigid dose thresholds that the 2016 version had been misapplied as hard caps and replaced them with individualized decision-making. The guideline explicitly warns against abrupt or rapid reduction in patients on long-term therapy. That matters because the opposite failure is also lethal. Fenton and colleagues in JAMA Network Open in 2022 found tapering was associated with increased long-term risk of overdose and mental health crisis. Fishbane and Pulikal's systematic review in pain medicine in 2019 examined what actually happens to pain during tapering. So this is not an argument for aggressive cuts. It is an argument for a low, stable, intermittent dose, arrived at gradually, with real treatment underneath it. I want to make one more argument because fewer pills is safer only sounds true if you ignore everything else in the system. A tablet count is a static number on a page. Safety is a process. Ours is built out of frequency and verification rather than unit reduction. Patients on long-term controlled substances are seen in person every 2 weeks, not monthly, not by telehealth. We do not provide telehealth for this population at all. Every patient brings every bottle to every visit for a physical count. Urine drug testing runs every 6 to 12 weeks, sent to an independent high-complexity laboratory using gas chromatography rather than a moderate complexity immunoassay, because immunoassay misses too much in a population that includes co-occurring addiction. Absence of the prescribed drug is treated as seriously as presence of an illicit one. It suggests diversion, and it gets investigated immediately. Every prescription is electronic. We issue no verbal orders and no telephone prescriptions, ever. If a pharmacy receives a phoned-in prescription claiming to be from us, it is not from us, and I want to hear about it that day. Every patient signs a medication agreement with a single designated pharmacy, no early fills, and no controlled substances from other prescribers without telling us. Violations end the relationship, not with a warning, with discharge. Now compare the two models honestly. One patient collects 60 tablets a month and is seen twice, counted twice, and screened regularly. Another collects 14 long-acting tablets and is seen once a quarter. Which one is actually being watched? The unit count is the least informative number in that comparison. It is simply the easiest one to put in a headline. Call me, not the front desk. Me. If a prescription from us looks wrong to you, I would far rather spend 10 minutes on the phone reviewing that patient's risk stratification and treatment progress than have you quietly refuse the fill and send the patient into withdrawal without telling anyone. And tell us what you see at the counter. Patients often present appropriately in clinic and behave completely differently at a pharmacy where their guard is down. That information is not otherwise available to us, and we act on it. Credible reports of aberrant behavior end the treatment relationship. Your corresponding responsibility and mine point the same direction. I am not asking anyone to be comfortable with a high tablet count. I am asking that we measure the right thing. Total daily exposure, receptor rest, function, mortality. Those are the numbers that decide whether a patient is better in 3 years. The tablet count decides how a spreadsheet looks. Pharmacists with questions, the clinic is 314-481-5000, and I can be reached directly on 314-852-5500. Text is fine, or at seva@pada.com.